Some NHS commissioners are introducing contracts that use capitated payments, which, broadly speaking, means paying one provider or group of providers to cover all the care of a specific group of people. But how could this help make services more integrated and patient-centred? To understand, it helps to look at how we pay for healthcare now. At the moment, different commissioners pay lots of different providers for delivering different health and social care services to individual patients. But often, the same people need to use several services at the same time, especially if they have more than one health problem. The different services in the local health and care system all try their hardest for the patients, but the system as a whole doesn't necessarily serve each person in the way that best suits him or her. With capitated payments, all the commissioners in a local area can contract a lead provider or provider network to meet all of the healthcare needs, physical, mental, or social, of a given group of people, and pay a regular lump sum for each individual in the group. Now, just one lead provider with a regular income is responsible for arranging and paying all the services those people need in line with agreed quality and outcome standards that are written into the contract. And patients in the group help to specify those standards. But you might ask, what difference will patients see? Won't the lead provider just make loads of contracts with other care providers and people will still have to shuttle between them? Well, capitated payments tackle that risk by aligning financial rewards for service providers in the network, so all the providers are incentivized to make sure the group of people they serve are happy with their care. Research indicates that most people with multiple conditions would prefer to have as much of their care as close to home as possible, and for all their care to be more joined up. The lead provider is in charge of making that joined up care happen, and all the providers in the network are rewarded when they succeed. Imagine a lead provider holds the capitated contract for meeting all the health and care needs of people with multiple conditions in a local area. Commissioners carefully scrutinize the network's performance of the contract. Is it delivering the kind of joined up care that patients in a group have asked for? And how is it doing compared to similar provider networks? Commissioners only hand over the last part of the budget to the lead provider when the performance measures show that the network is delivering the health and quality standards specified in the contract. Then, the lead provider shares this bonus with the other providers in the network. There are lots of ways of organising patients' care in more seamless, user-friendly ways once you start looking at the whole care system from the user's viewpoint, and make a single budget holder accountable for organising it like that. Commissioners may worry that this will make care cost more than it does today. There is more research to be done on this important point, but evidence so far from places in Spain, Germany, and the US where they use capitated payment shows that when it's used well, patients can become happier and healthier at the same time as costs come down. That's partly because capitated payments give the lead provider an incentive to focus on prevention and health management, as well as a bonus for improving outcomes. If lead providers manage to keep costs down, they get to keep a share of any savings to invest in new services. The incentive works like this. The lead provider's total capitated budget is based on the estimated needs of people in a defined group and the cost of treating them. If the provider's arrangements deliver the health outcomes and experiences that service users want for less than anticipated, there's a net gain to the local health system. Some of this goes back to the commissioners to spend on more care for their local population. Some of it the lead provider can keep to invest in improved services to people in their group. Of course, providers mustn't cut costs at the expense of quality, but remember, they only get paid in full if they meet the quality standards outlined in the contract. Evidence shows that providers in networks do in fact tend to keep costs down by investing more in prevention, helping patients to stay healthy and stay out of hospital, which is what patients mostly want. But they're also geared up to undertake essential interventions. There are still big questions hanging over capitated payments and more risks to tackle. How can all the commissioners pool their budgets? How can commissioners and providers share risks fairly? How can providers in a network challenge the lead provider? Across the NHS, people experimenting with capitated contracts are finding answers to these and other questions. Monitor, and the other central NHS bodies support these experiments and are monitoring and sharing the results so that everyone can learn from them. If you think capitated payments might help your local health system deliver good value and integrated care, you'll find more useful information here.